Hello, my name's John Wilding from the University of Liverpool, and I'm going to talk today about GLP-1 analogues for the treatment of obesity and whether we've reached the limits with currently available therapies. I think it's firstly important to highlight the fact that although we tend to use body mass index as a measure of body weight, and the classifications are listed in this table here, that obesity is actually a complex disease related to an excess amount of body fat, and it is where that fat is distributed that determines the disease of obesity. So it's not just about how much fat we have, which produces some of the mechanical consequences of obesity, but also the dysfunction and the metabolic dysfunction of that adipose tissue that results in some of the metabolic consequences of obesity, such as type 2 diabetes and cardiovascular disease. The consequences of obesity are many, and I think it's important to remember that we can classify these as mechanical, related to this excess in fat mass, metabolic, related to the inflammation and other factors that are associated with obesity, such as type 2 diabetes, cardiovascular disease, and hormone-dependent cancers. And also, we have to remember that obesity is a condition that can also affect mental health. If we're going to help people with obesity to lose weight, we have to think about what our goals are. Of course, the first goal is to achieve some weight loss. And this is generally done through a dietary restriction, although increased physical activity can also contribute towards that. But the really hard part, as I'll show you in more detail as we go through the presentation, is maintaining that weight loss in the long term to prevent weight regain and therefore achieve the really important clinical benefits to reduce the mechanical, metabolic and mental health consequences of obesity, including reduction in the risk of diabetes, reduction in cardiovascular disease, risk factors, and also improving quality of life. This slide shows the reality of the difficulty in maintaining weight loss. This shows a number of different studies where weight loss has been achieved over usually about a year with an intensive lifestyle intervention that includes dietary restriction, behavioral change, and an increase in physical activity. What I think is most interesting and most challenging about this graph is the long-term follow-up. And we can see that in all of these studies, people tended to gain weight over time, and that in many cases, and in some of the studies, in fact, people exceeded their baseline weight 3 or 4 years after the study completion. So this is the real challenge of weight management, long-term weight maintenance. Why is it that we find it so difficult to maintain our body weight once we've lost weight? Well, this study, I think, highlights this very beautifully. Here we see a study where people have been subject to quite strict dietary restriction using a very low calorie diet, liquid meals, less than 800 calories a day for about 10 weeks. And you can see that they've lost about 12 kilograms in body weight over this time. And then subsequent to that, as with most weight loss studies, they continue to get dietary advice, although they've returned to normal food. And we can see that weight regain gradually occurs so that in the subsequent year after the diet, they've regained about half of the lost weight. So why is it, having successfully lost weight with the diet, that they regain that weight? When we ask people during a test meal situation in the laboratory how hungry they feel, what we find is that immediately after completing the diet, as you might expect, they tend to feel hungrier than they did before they started the diet. What's even more interesting is that even once they've regained half of that lost weight, they're still feeling as hungry as they did the day they finished that diet. And in fact, we expect that that would continue until they had regained all of the lost weight. We now also understand the physiological basis to that. And that is because many of the hormones that come from our gastrointestinal tract and from adipose tissue that help regulate body weight tend to change in a direction that would make us feel hungrier and less full after a meal after weight loss. So we can see here that in the top left-hand panel, for example, that the hunger hormone ghrelin is increased immediately after the diet and is still higher at week 62. In contrast, some of the satiety hormones, shown here peptide YY, amylin, and cholecystokinin, are all lower after the diet and still lower at week 62 when people have regained half of that lost weight. And we see similar changes for other gut hormones, particularly, for example, glucagon-like peptide 1, shown here on the right. And of course, as subsequent to this, we also see levels of insulin as a measure of insulin sensitivity, but which is also a factor involved in satiety, tending to be lower and remaining lower some weeks after the diet has been completed. We also tend to see that the adipose tissue hormone leptin tends to fall with weight loss. As BMI goes down, the leptin goes down, and this is another signal from the periphery to the brain that is making us feel hungrier after a diet. So if we put all that together, the effects of energy restriction, if we take someone who is obese or overweight and we ask them to restrict their energy intake, which we call dieting, they lose weight successfully. We then see a reduction in leptin, a reduction in satiety hormones, an increase in hunger hormones, and also a reduction in energy expenditure. All of these things tend to conserve energy, make us feel hungrier, and eventually mean that we will regain all of that lost weight. So this means that diet and exercise are important ways to help people lose weight, and some weight loss can be sustained in some people. But we do need to think about the use of medications to support this. In the UK and in the European Union currently, there are 3 approved medications for weight loss. There is the lipase inhibitor orlistat, which can be bought over the counter at a lower dose or prescribed at the higher dose of 120 milligrams 3 times a day. This tends to produce fatty stools and diarrhea. Many people struggle to use this medication long term, but it does have modest effectiveness. We also have the drug combination naltrexone and bupropion, which work on the central nervous system control of appetite, and again are reasonably effective, producing an additional weight loss of 3 or 4 kilograms over and above diet and exercise, which can be sustained certainly up to 2 years. This is not currently approved for use by NICE in the UK, and I won't be discussing this further, although it is available in some countries in Europe. Finally, we have the GLP-1 receptor analog liraglutide, which is a drug already approved for diabetes treatment at the lower dose of 1.8 milligrams, but here at the 3 milligram dose is approved for weight management. And I'm going to focus the rest of my talk on the GLP-1 receptor analogues and their role in as treatments for obesity. So just to remind us a little bit about what GLP-1 is and its importance in weight regulation. GLP-1 is a gut hormone. It's secreted from the jejunum and ileum in response to food ingestion. And it has a couple of main roles within the body. The first of these is its well-known and well-recognized effect on the pancreatic beta cells to enhance insulin secretion in response to glucose. It's the archetypal incretin hormone, and that's why it's used as a treatment for diabetes. It also tends to reduce glucagon secretion, so it has an effect on the alpha cells in the islets, again contributing to the improvement in blood glucose control, and again another reason why it's used for treatment of diabetes. It also delays stomach emptying, but perhaps most relevant for this discussion is that it also signals to the brain that we are feeling full after a meal, and is one of the important satiety hormones that I mentioned earlier that tend to be reduced after we lose weight with dieting. We have a number of glucagon-like 1 receptor analogues that are used or approved for the treatment of diabetes. This shows here the structure of human GLP-1, and we can see here that there are some weekly analogues that are based on the Gila monster saliva product Exendin, such as Exendin 4 and lixisenatide, and others that are more closely related to the human GLP-1 molecule, such as liraglutide, which is a once-daily preparation, semaglutide, a once-weekly preparation, and a couple of others here, dulaglutide, and one that is not widely used now because its development was stopped, called albiglutide. If we look at trials of these GLP-1 receptor agonists where they've been used primarily to treat type 2 diabetes, so for their glucose-lowering effect, what we can see is that the effect of these medicines on body weight is quite varied. So, for example, if we look at this trial here, which compared dulaglutide with exenatide, we can see that the amount of weight loss was really quite modest in this study. Whereas studies that used, for example, semaglutide tended to produce much greater weight loss. So all of these drugs are not exactly the same in terms of their ability to access the central nervous system and therefore have an effect on body weight, although they are all relatively close in terms of their effect on blood glucose levels. One possible reason for this is the fact that the drugs liraglutide and semaglutide are actually coupled to a free fatty acid, which may allow access to the brain a bit more easily than for some of the other molecules. We also have known for many years that GLP-1, this is a study that I was involved in when I was working at the Hammersmith Hospital in the 1990s. You can see that what we showed in this study was that in rodents given GLP-1 after fasting, it was possible to reduce their food intake, and we found that this was related to activation of neurons within the brain, particularly in the paraventricular nucleus of the hypothalamus, and also other areas such as the central nucleus of the amygdala that are also involved in food intake. That's of course in rodents, but we also know that this is true in humans, and this study from GLP-1 infusions using GLP-1 infusions in PET imaging shows that there is activation of neurons within the hypothalamus and also some other brain areas when humans are infused with GLP-1. So we know that GLP-1 can access the brain. And in fact, if we look at a number of different studies where GLP-1 has been infused into humans and appetite has been measured, the meta-analysis shows that this is effective at reducing energy intake, completely consistent with what we've seen with the trials in diabetes with modest weight loss in people with diabetes treated with GLP-1 receptor analogues. So what happens if we push the dose a little bit higher? This is a study using liraglutide, the once daily GLP-1 analog, at the 3 milligram dose, showing that it does indeed reduce energy intake. We can see that in a test meal situation, we see a reduction of about 500 kilojoules, so about 150 calories reduction over the course of a test meal. What we don't see is any change in energy expenditure. In fact, energy expenditure tends to be a little bit lower because people have lost weight. And as I already showed you, there is a tendency to reduce energy expenditure as you lose weight. In clinical trials where liraglutide 3 milligrams has been used as a treatment for obesity, and here I show you data from the SCALE Obesity and Prediabetes study, which was a large study with over 2,500 participants randomized to 3 milligrams of liraglutide or placebo on the background of diet and exercise. We can see here the placebo group lost around 2.7 percentage points in body weight, whereas those patients treated with liraglutide lost 7.1 percentage points in body weight over 3 years of treatment. Once we stop the treatment, there is some weight regain, as you might expect. If we look at how that translates into some of the metabolic consequences of obesity, we can look in this group of people who all had pre-diabetes at baseline, that the number of people who developed diabetes during the follow-up of the trial was much less in those people treated with liraglutide 3 milligrams than it was in the placebo group. And remembering that there was there were twice as many patients randomized to liraglutide than to placebo in this study. So this actually results in a more than 3-fold difference in the rates of developing diabetes when treated with liraglutide compared to placebo. And importantly, because this is a glucose-lowering drug, that effect persisted even after the treatment was stopped. In fact, if we look at the group of trials that were done with liraglutide 3 milligrams, we can see that there was consistent weight loss across these trials in people with pre-diabetes or obesity without pre-diabetes. The average weight loss at 1 year was around 8% compared to 2.6% with placebo, and about 60% of people achieved a weight loss of 5% or more. In a trial where people were given a very low energy diet and then randomized to liraglutide or placebo after they'd lost about 5% or more of body weight, we can see that there was an additional 6% of weight loss, and about half the people achieved a 5% additional weight loss or more. In people with diabetes, we see similar results, and also in people with obstructive sleep apnea. So this drug, liraglutide 3 milligrams, is now approved for the treatment of obesity. Turning to safety, I think it's important to emphasize that the overall safety program at the higher dose of liraglutide used for people with obesity is consistent with what was seen with the 1.8 milligram dose that is widely used for the treatment of type 2 diabetes. The most common adverse events seen are nausea, diarrhea, and constipation. These tend to occur early during treatment and resolve once the dose has been titrated up to the maximum dose, which takes the first 6 weeks of treatment, and most are mild, moderate, and transient. We also tend to see a slightly higher rate of gallstone formation, which can lead to cholecystitis and occasionally gallstone-related pancreatitis. And this is well recognized to occur with weight loss, and indeed occurs in other situations where there is significant weight loss, such as after bariatric surgery. In terms of the metabolic effects, we tend to see, as well as the reduction in progression to diabetes that I've already shown you, we see improvements in blood pressure and lipids. And although there is an increase in pulse rate, this is well recognized with GLP-1 receptor analogues and does not seem to be associated with an increase in cardiovascular risk. Indeed, we know from the LEADER trial in people with type 2 diabetes at the 1.8 milligram dose that liraglutide is in fact associated with a lower risk of cardiovascular events, and there was no excess seen at the higher dose in the obesity trials. In the UK, NICE has reviewed the liraglutide 3 milligrams, and it is approved for use within specialist weight management clinics for people with pre-diabetes who have additional high cardiovascular risk. So this is a new treatment that is now very recently been made available on the NHS in the UK for people with severe obesity. I'd now like to turn to talk about the weekly GLP-1 analog, semaglutide. Semaglutide is a weekly GLP-1 analog that has been available for treatment of diabetes for a couple of years now. And this trial actually used a daily dose, but was a phase 2 study to establish the effectiveness of semaglutide in the treatment of people with obesity. You can see that 5 different doses were tested in comparison to diet and exercise, lifestyle intervention, and also the 3 milligram dose of liraglutide. What we saw in this trial was weight loss that in the placebo group was around 2.5%, and you can see that there is a dose-dependent effect to reduce body weight. And at the highest dose tested, which was 0.4 milligrams daily, we saw weight loss over 52 weeks of just under 15 kilograms. This is nearly double the weight loss that was seen with liraglutide 3 milligrams. As a result of this phase 2 trial, a full clinical trial program was developed with semaglutide, now using a weekly dose that is equivalent to this 0.4 milligram dose of 2.4 milligrams weekly, which compares to 1 milligram weekly, which is used for the treatment of diabetes. The program here was called the STEP program, and there are a number of different trials in it, and 4 of these trials have now been completed. I'm going to focus mostly on the largest trial, the STEP 1 trial, that used semaglutide 2.4 milligrams weekly for the treatment of people with overweight or obesity without type 2 diabetes with a 68-week trial. But I will also mention briefly the results of the STEP 2 trial in people with type 2 diabetes, the STEP 3 trial that combined liraglutide with intensive behavioral therapy, and the STEP 4 trial that looked at long-term effects. This is the study design for the STEP 1 study. We included people with a body mass index of at least 30 or those over 27 with at least one weight-related comorbidity. This trial did not include people with diabetes, those who'd had prior surgical treatment, or who had recently used other anti-obesity medication. You can see here that the dose was titrated over a period of about 16 weeks, so every 4 weeks the dose is escalated until people reach the 2.4 milligram dose, and with a mock titration in the placebo group. Everybody is supported with lifestyle intervention to reduce their energy intake by 500 kilocalories a day and to try and increase their physical activity to at least 150 minutes per week. If we see what happened in the STEP 1 trial, we can see that the placebo group who received diet and exercise throughout lost 2.4% body weight compared to liraglutide, and in the intention to treat analysis shown on the left here, a 14.9% weight loss. If we look at those individuals who stayed on treatment throughout the trial, the weight loss is slightly greater at 16.9%. But I would highlight that over 90% of patients were able to complete the trial. If we look at the proportion of people who achieved clinically relevant weight loss of at least 5%, that was 86% in those patients treated with liraglutide, compared to 32% with placebo. And looking at higher thresholds of weight loss, we see over 2/3 achieving a 10% weight loss, over a half achieving a 15% weight loss, and nearly 1/3 achieving 20% weight loss with semaglutide 2.4 milligrams. Did this translate into other clinical benefits? Well, certainly we saw reductions in waist circumference as a marker of central adiposity, significant reductions in blood pressure of around 6 millimeters of mercury systolic, and improvements in some of the physical consequences of obesity, with improvements in both the SF-36 and impact of weight on quality of life, physical functioning scores. We also saw improvements in these people without diabetes in HbA1c, fasting glucose, and in diastolic blood pressure. And in terms of lipid profiles, again, we see favorable effects with reductions in total cholesterol, LDL cholesterol, particularly VLDL cholesterol triglycerides, with an increase in HDL cholesterol, and a reduction in C-reactive protein as a marker of adipose tissue inflammation or general systemic inflammation. In terms of adverse events, there was nothing, again, unexpected here. We do see higher rates of the gastrointestinal adverse events that tend to occur early during treatment and resolve over time. And again, we see an increase in gallbladder-related disorders as we saw with liraglutide. I'd just like to highlight a little bit of extra detail here about a sub-study that looked at body composition during the STEP 1 trial. In 140 people who had a BMI below 40, we were able to use DEXA to measure total body fat mass, lean body mass, and regional visceral fat mass at the L4 level. These are the baseline characteristics of the patients included in this part of the trial. You can see that we're a little bit younger, about 3/4 were women, mostly were of white race, and the average body mass index was a bit lower than in the overall trial because of the cutoff at 40, but nevertheless significantly obese with a BMI of around 35 and a body weight of just under 100 kilos. These people did not have diabetes, but they did have a significant proportion of their body weight being adipose tissue at around 44%, as you can see here. If we see what happened to body composition, you can see on the right here in the placebo group that this really didn't change. 44.6% body fat reduced slightly to 44.2%, and lean body mass really didn't change significantly. In contrast, in those people treated with semaglutide, we saw a reduction in the proportion of body weight that was fat from 43.4 to 39.4%, and an increase in the relative amount of lean body mass from 54 to just over 57%. So presenting this as the change in body composition of baseline to week 68, we see a reduction in 3.5 percentage points in the proportions of a total fat mass compared to virtually no change with placebo, an increase in the proportion of lean body mass of around 3%, and a reduction in regional visceral fat mass of around 2%. Another way of looking at this is to actually plot in those patients treated with semaglutide 2.4 milligram, the change in body weight to the change in lean to adipose tissue fat mass. And what we can see is that in general there is quite a clear correlation here, so that those people who lose the most weight have the greatest improvement in body composition in terms of the ratio of lean to fat mass. And if we look at this using a cutoff of the 15% weight loss, which was achieved, as I've already said, in just over half of participants, we see that in those patients with a weight loss of 15% or more, they experienced the biggest improvement in this ratio between lean body mass and fat mass. So I think this gives us an explanation as to why we see these metabolic improvements, because we're reducing both fat mass and particularly visceral fat mass. I'm just going to summarize the other trials in the STEP program now in this slide. And we can see here that the STEP 1 trial that I've already shown you in detail, 14.9% weight loss compared to 2.4% with placebo. We tend to see a bit less weight loss in people with type 2 diabetes in the STEP 2 trial, but nevertheless significant weight loss of just under 10% in those patients treated with type 2 diabetes treated with the 2.4 milligram dose weekly of semaglutide. In the STEP 3 trial, where there was a more intensive lifestyle intervention, we tended to see greater weight loss in the placebo group and also greater weight loss in the semaglutide group. And in the STEP 4 trial, where everybody received semaglutide for 20 weeks and then they were randomized to either continue semaglutide for weight maintenance or to switch back to placebo, what we saw was a 17.4% weight loss. In those patients continued with semaglutide, we saw additional weight loss, whereas in those patients switched to placebo, there was weight regain after that initial weight loss period. Finally, I'd like to, just while we're talking about semaglutide, I'd like to highlight the fact that there is an ongoing cardiovascular outcome trial called SELECT. This is now randomized 17,500 people with a body mass index over 27 with established cardiovascular disease, prior MI, prior stroke or peripheral arterial disease, to semaglutide or placebo. And this is an event-driven cardiovascular outcome trial that we hope will report in the next 3 or 4 years, and will tell us whether these improvements in cardiovascular risk factors that we see with semaglutide will translate into a reduction in cardiovascular events. And I think this certainly seems to be getting close to the limits of what we might see in terms of the benefits of GLP-1 receptor analogues for the treatment of obesity. Nevertheless, we may actually be able to go further. We know that a number of other gut hormones are involved in the regulation of appetite, including glucagon and GIP and amylin, and there are a number of co-agonists in development that might have benefits not only for people with diabetes, but also for people with obesity. And just to remind you that using these agents, it may be possible to incorporate the fact that most of the GLP-1 related molecules come from the same precursor molecule, the proglucagon gene, and this includes molecules such as oxyntomodulin, glucagon itself, as well as GLP-2 that may also have effects on appetite. So I think there's still a little way to go in terms of developing new agents that act via this system. Just to give some examples here, this is the results of a trial with a compound called MEDI0382, now known as cotagitide, which is a dual GLP-1 glucagon agonist. And we can see here in a short trial in people with type 2 diabetes that it was effective at lowering HbA1c, but also that it produced modest weight loss. I would highlight that this is a short-term trial of only 3 months duration, and that the main aim here was to treat type 2 diabetes rather than to treat obesity. Another agent that is in clinical development is this GLP-1 GIP dual agonist, which is also known as tirzepatide. And this is a combination drug that is able to act on both the GLP-1 and the GIP receptors. And in this phase 2 study with tirzepatide, again in people with type 2 diabetes with the 26-week treatment, we saw really quite impressive reductions in HbA1c, for example, compared to the GLP-1 receptor analog dulaglutide at its standard dose of 1.5 milligrams weekly, but also much greater weight loss, 11.3 kilograms at week 26 in a population of people with type 2 diabetes. Like other GLP-1 receptor agonists, this did also cause some issues with gastrointestinal adverse events, but this is being addressed by changing the dosing regime for the ongoing phase 3 trials. Finally, I'd like to come back to semaglutide. And I'll remind you here, these are the data from the Step 4 trial that I showed earlier in a different form. Everybody gets semaglutide for 20 weeks, and then they're randomized to switch to placebo or to continue on semaglutide, and we saw that weight loss of over 18% in that trial. In this early trial, we're combining semaglutide with an amylin analog. And amylin is another gut peptide, in fact, secreted from the pancreas that seems to be involved in appetite regulation. And we can see that just over 20 weeks here, combining semaglutide with amylin, we are seeing a weight loss of 17%, with 66% of people achieving a 15% weight loss or more in just 20 weeks. So I think this may be now the way forward, where we're combining different gut hormones to actually eventually be able to get close to what we see with bariatric surgery. Bariatric surgery is the most effective form of weight loss, and with gastric bypass surgery, we see weight loss of 30% or more. And semaglutide currently is somewhere between 13 and 18%, as I've already shown you. But I think by adding amylin or other compounds to semaglutide, we may be able to get closer to what we see with bariatric surgery. So to summarize, I hope I've convinced you why weight loss with diet and exercise is difficult, because of changes in appetite and energy expenditure, which are at least due in part to changes in gut hormones such as GLP-1. And we know that GLP-1 is physiologically relevant for weight regulation, that GLP-1 analogues are effective at causing weight loss in diabetes, although they're not all the same, and that we already have one GLP-1 analog, liraglutide, which is approved for weight management, but we have a new one, semaglutide, which is nearly 3 times as effective, and this is currently under regulatory review. we still haven't reached the limits because we may be able to combine gut hormones to produce more potent ways of helping people lose weight in the future. Thank you very much for your attention.